Good morning, we're Team 5. It's a pleasure to join this online competition and to get a chance to present you with our proposal on one-year COVID-19 vaccination program in Japan. Before we move on to goals and key activities of our program, let me share with you some brief COVID-19 status of Japan. As of March 17, these numbers are showing no sign of decline at all. As you can see in this chart, which shows the vaccinated population of two adjacent countries in Eastern Asia, the number of people with at least one dose of vaccine in Japan is only 0.2%, which is considered quite low when compared to the global status. So in this urgent situation of low vaccination rate in Japan, we've set our goal for one-year vaccination program to achieve 70% of national coverage. Then, how are we going to reach 70%? As we are now observing in the real world, the optimization for the vaccination schedule is of crucial importance for achieving successful immunization. And that's why I first want to start with vaccine prioritization plan. We plan to start from healthcare workers, then to the age group, adults, and vulnerable population. It may not seem so novel at first sight. However, we refer to the mathematical models to prioritize properly based on the effective reproduction number of 1.08 in Japan. According to a recent R&D seminar in South Korea, where the goal is to minimize death, vaccination priorities can be considered and calculated based on the effective reproduction number of the specific society. Though it actually also depends on the amount of the vaccination, it shall be ignored in our case assumptions. The picture on the right shows Japan's effective reproduction number as of March, which is about 1.1, included in the orange portion of the graph. So according to the mathematical model, it is possible to minimize the number of events when vaccination is scheduled in the order of healthcare personnel, elderly, adults to the minor. Also, there's one more thing I want to point out at this moment. Since Japan is classified as a top-aged country, the senior group consisting of nearly 30% of the total population. In this 10-minute presentation, we're trying to focus specifically on the healthcare workforces and the age group. We assume that the outer population will be persuadable when these 30% get successfully vaccinated. Aside from optimizing scheduling for the vaccination, we found two major problems that need to be tackled to speed up the vaccination. The first one is a deeply rooted hesitancy towards vaccination prevailing in Japanese society. The other one is a local distribution problem. So we came up with two different approaches to resolve this problem, one for each distinct target cell population. Let us first start with healthcare workers. As shown on the right side, they can be classified as hesitant acceptor for the vaccination. Though they have knowledge and rationality enough to assess the safety of the vaccine, the scarcity of the data and adverse events at this moment, and the prevailing hesitancy in vaccination is keeping them hesitant. But one of the major features of the subpopulation is that they're more exposed to and thus more open to accept new credible medical information that the overall population would do, which makes it easier to assure them with objective safety data and the vaccine. So we can first start using the strategy of convincing them with a causality assessed data in mobile platform. Then, how should we present such data effectively to guide them to personal assurance of vaccine safety while maintaining the data transparency, which might include the public announcement of rare severe vaccine ADRs that have been reported? We should let them only to conduct sound comparisons. First, we should guide them to care only on the ADRs occurred to those with similar baseline physical conditions. Next, they should be guided to compare the ADRs rate of the vaccine with those of other vaccines, such as flu and MMR. Lastly, they should be guided to watch the stabilizing trend of the reported ADRs in time series. Instead of the number of the total cases of ADR accumulated over time, let them see the diminishing trend, converging to safety. Now, let's move on to discussions on how to distribute the collected data and how to speed up the vaccination among healthcare workers. Japan already has JADAR, its own national ADR reporting system, but they're not connected to mobile platforms like FreeSafe as prepares, which makes it hard to update the adequate vaccine ADR information on time. So they need to be remodeled into the one interlocked with mobile reporting applications. This new system will be reporting ADRs, grouping by recipients' baseline characteristics while keeping transparent disclosure of vaccination information. In order to prevent inappropriate words on rare ADRs, reported rare events has to be confirmed by professionals being uploaded to public database. With this new mobile link system, doctors are informed about individuals' ADRs on time. Our next strategy deals with encouragements with compensations. Vaccination holidays will be given for the healthcare workers who are working actively in the medical field. This will serve a dual purpose. It will decrease vaccination hesitancy caused by worries over having to work even after side effect gets them. Furthermore, the publicization of the vaccination holiday for early vaccinated healthcare workers can be shown to the general public as a good example of natural recovery from vaccination without serious side effects, reassure them for the safety of the vaccine. Also, monetary incentives for those who guide patients successfully to vaccinations the most will be given monetary incentives. Next subpopulation of our consideration is the elderly above 65 years old. To minimize their hesitancy and ultimately guide them to get vaccinated, we're planning to execute social marketing campaigns. Prior to conduct the marketing campaign, we created the marketing segmentation strategy by dividing entire target population into 3 segments. For segment C, they are unaware of the possibility of the infection, so the main strategy for this group should be changing their awareness. Segment B, though, are aware of the possibility of the COVID-19 and consider them as vulnerable ones. So the main goal should be to convince them to vaccinate it, since COVID-19 may be detrimental to their health. Lastly, for segment A, they are aware of the COVID itself and the severity of the virus, but they're not yet motivated to get a shot. Majority will be the ones hesitant due to the side effect and safety issues. So, for the previous slide on marketing segmentation, we divided our potential vaccine recipient into 3 groups, segment A, B, and C. The key activities vary by each segment. The strategy for segment A is to motivate them to get vaccinated by sharing case stories of those who had similar baseline characteristics. Since the majority of them are unreachable to online systems, each community center can mail some updated stories every 2 weeks. For segment B, it is important to inform them about the severity of the COVID-19 so that they can move on to segment A. To do that, we encourage each community center to educate their seniors, since it is a method well known to effectively deliver the important messages. Lastly, it is needed to focus on improving awareness for segment C. In order to improve their awareness, we are planning to advertise various information regarding COVID-19 through newsletters or in public transportation. Now, we introduce the use of community-based integrated care as a tool for increasing the vaccination rate of the elderly. The 3 major hindrances to elderly vaccinations are the decreased mobility of the elderly, low awareness of the necessity of the vaccination, and the intractability of the individual's vaccination history due to the loose connection with the social platforms. And we aim to tackle this with a community-based integrated care system, which can reflect the unique regional characteristics of Japan. Coordinators, which will play a crucial part in the community care, should initiate the vaccination awareness campaigns in advance, which will be done in places where seniors can be easily gathered to participate in the campaign, such as community centers, housing for the elderly, or so. Actual face-to-face education on vaccines shall be the role of Level 3 coordinators, and Level 2 coordinators will be in charge of the monitoring Level 3 coordinators and maintaining daily living zone scale campaigns. Above these 2 levels, Level 1 coordinator shall be in charge of the large-scale vaccination awareness campaigns in municipality scale. Now, the vaccination model in the community-based integrated care is largely divided into 2 components, one for the metropolitan city suburban, and the others for remote area. Regional comprehensive centers in the metropolitan city and suburbs are defined to be the ones which can be reached by less than 30 minutes from seniors to visit. And the regional comprehensive centers are remote, whereas they're the ones that take more time. In particular, because of the decreased mobility of the elderly, medical staff should directly visit the patient's home for the vaccination in a remote area. And furthermore, with a joint effort from the private hospitals, the vaccination speed shall be accelerated greatly. In conclusion, the community-based integrated care strategy we propose has 3 phases. For phase 1, the vaccination awareness campaigns with local coordinators, which will raise awareness on the vaccination among elderly. Then, for the second phase, via 2 tracks on immunization strategy based on accessibility, fast vaccination should be made on the elderly who live in the remote areas. Lastly, for the phase 3, by integration of the ICT system with the pre-existing community care services, vaccination-related data shall be collected and used to establish a novel integrated system with usable data on regional scale. This system will play a key role in reporting, maintaining data on vaccination records and various events. And this is the entire vaccination strategy timeline. First of all, mobile platform remodeling for healthcare workforce and creating a website for patient will be implemented immediately in April, and it will be maintained throughout the entire period. but monetary incentives for those who guide a patient successfully to vaccination will be given only in the early stages. Each marketing campaign for the elderly and the community-based integrated care is conducted throughout their vaccination period. So afterwards, the overall awareness of the vaccinations will be improved to reach 70% of the vaccination rate and establish a herd immunity system. Lastly, as for budgets, 45.5% of the total budget is allocated to vaccination program for healthcare workers. And the remaining 53.6% of the total budget goes to elderly programs. What I want to point out here is that since community-based integrated center-related costs should be subsidized by the government, the associated cost shall be zero. This is the end of our proposal on the vaccination program for Japan. Thank you all for your attention.